Good evening, everyone. I'm Dr. Michael Diamond, the biohacking cardiologist and the heart attack and stroke prevention expert. Tonight's going to be all about lipids and treatment options, should you even consider lowering your lipids. So thank you for joining tonight. We got this streaming on Facebook, Instagram, and on Zoom right now. So we'll get started here in just a moment. So start recording. We always have a backup. I learned that one. So, all right. So we'll get started. And those who join later, they can catch the replay. It'll always be available up on my YouTube channel as well as my Instagram live feed. So tonight, again, we'll be talking about what are lipids. I did do a talk last week. It's up on IGTV. All about the kind of what are particles, why particles are more important than knowing what your actual cholesterol levels are. Tonight's going to talk a little bit more about treatment options. So first, I want to talk about primary prevention versus secondary prevention. So primary prevention, you've never had a heart attack, stroke, stents, bypass. What do you need to do versus somebody who's already had one of those events? So people who've already had events, they should more likely for sure consider standard of care treatment. There's data that the number needed to treat those people is much less for those people to get benefit. When you're speaking of primary prevention, you've never had an event, you have to treat more people. Sometimes you have to treat, depends on which studies you're looking at, but it can be anywhere up to 200, 250 patients, for one of those people to benefit. So the other 200 patients or so don't get a benefit and take the medicine the entire time. So as stated last week, cholesterol is a substance that's needed in every cell in your body. It wasn't put into you by Mother Nature to give you a heart attack or stroke. It's a repair molecule. It's used to make your sex hormones, to make your vitamin D, to make your bile acids to digest your fats, it makes your cell membranes, the outer shells of your cells. So cholesterol is not the boogeyman. But if cholesterol gets damaged, it's the damaged cholesterol that sets off an immune response. Your body then thinks it's a bacteria, sends out the warriors to go fight it, and then the arteries get damaged as innocent bystanders. So there's always going to be cholesterol inside plaque that's in your arteries, but it's not necessarily the number one thing that's putting the plaque in the first place. That's oxidation, inflammation, and autoimmune dysregulation, or immune system attacking yourself. Those are much more likely causes. The cholesterol is kind of innocent bystander in those cases. So cholesterol is needed in your brain. Your brain makes all the cholesterol it needs, so it doesn't need your liver to make cholesterol and transport it up to your brain. Your cells make the majority of their cholesterol, so what's floating around your blood system has very little to do with what's inside your cells and what's inside your brain. So lowering your blood levels of cholesterol is not going to lower it so much in your brain. There are some, advanced blood testing you can check to see, what is your cholesterol production, so that maybe you're pushing it too far if you're trying to lower it. Maybe you need to dial it back. But there are certain goals you may want to kind of hit. So, before I talked a little bit about primary versus secondary prevention. So if it's primary prevention, you got a higher barrier before you're going to start considering taking pharmaceutical agents. If you have familial hyperlipidemia, which is a genetic abnormality, and between 1 and, depends on what types, but 1 in 1,000 to 1 in 10,000 have a certain gene that makes them make significantly high levels of lipoproteins. And these people potentially can, if they have a double abnormal copy, they can have heart attacks in their teenage years because they have so much cholesterol going around the system, and these particles, the particles get damaged, and this is basically like more shots on goal. More particles are banging into your arteries, more likely that some of those are going to get stuck in the walls of the artery. So those people, even if they've never had a heart attack or stroke, likely are going to end up on lipid-lowering therapies at a very young age. Otherwise, start with, test, don't guess, something I learned from Dr. Khan. There are certain vascular inflammatory, or I should say vascular testing you can do. There's a test that looks at your endothelial function, the inner lining of your blood vessels. If your endothelium is abnormal, you need to fix what's causing that, because if you don't fix that, the cholesterol, the endothelial dysfunction is like a Trojan horse. Then the cholesterol gets into the walls of the artery and starts depositing the damaged cholesterol once it kind of gets stuck in the wall of the artery. If it never goes past the endothelium and gets stuck in there, you're less likely to develop plaque in the artery. Another test frequently do in the office called a carotid entomomedial thickness scan. It's an ultrasound of your neck artery. Looks at the thickness of the wall artery. The thicker the wall, the more inflammation in the wall of the artery, more likely that those phospholipids, I should say the lipoproteins, are delivering a cholesterol payload into the wall of the artery. And then a later stage test is called a CT coronary calcium score. It's a low-dose radiation scan of your heart arteries. You should not have calcifications in your artery. Calcifications in your arteries indicates that plaque is building up in your arteries, and it's, the body's repair mechanism is putting a hard cap over it. Anytime you see calcifications there, there's always going to be soft plaque there as well, and soft plaque tends to be more vulnerable, more likely to cause a heart attack or stroke than the calcified plaques do. So if your calcium score is 0, it's not a perfect test, but you're extremely low risk of a heart attack or stroke. If your score is 0 and you have, quote, high cholesterol, most likely you're going to be doing lifestyle interventions, potentially nutraceuticals. Rarely you're going to jump to pharmaceuticals to lower, quote, high cholesterol, without proven vascular disease, and that's even in the traditional lipid lowering guidelines. If you have a calcium score over 400, unless you have a major contraindication to lipid lowering therapies, you should consider potentially taking therapies. And tonight I can't make an exact yes you should take it, no you shouldn't. This is more educational tonight. If you have actually specific questions, talk to me in my office. But those are kind of the three kind of tests that can tell you, how healthy are the arteries. If your arteries are very healthy, keep doing what you're doing from lifestyle. If your arteries aren't healthy, figure that part out, and then we'll deal with the lipid standpoint. But if you're going to talk about lipids, you got to get more than the total cholesterol, your HDLC, your LDLC, and triglyceride. Those are antiquated testing, and it does not predict your risk. Half the people that come into the hospital with heart attacks have, quote, normal cholesterol. So cholesterol is a snapshot in time when you do a blood test. It does not necessarily tell you where that cholesterol is going, and it doesn't tell you how well your body is clearing that cholesterol. So I said earlier, the majority of your cells are making their own cholesterol. About 20% of your cholesterol is made in the liver, and it packages it up in these little, carriers, like little boats or submarines, to drive them around the system, mostly to deliver triglycerides, which are energy, also to deliver these phospholipids, which help the cellular membranes as well. But how do you actually end up? Should kind of back up a little bit. If your liver is making a lot of the cholesterol, great, okay. Some of the cholesterol is needed for the liver's uses. Sometimes, other organs, the adrenals may need some cholesterol, so the package it up, send it out to the adrenals, make some more hormones. But over time, your body may need to clear some of this. The blood circulating around the system. That cholesterol particle is not to stay there all the time. Eventually, the liver, for the most part, grabs onto it to clear it. So your body is producing cholesterol in the liver that goes in the bloodstream, and there's a receptor called the LDL receptor. Kind of looks like a little catcher's mitt or a hand that sits on the outside of the liver. All cells have it, and basically if they're hungry for cholesterol, they express this. They put out their little hand, and I've heard it described as the thing from the Addams Family, for those who remember the Addams Family. But the little hand comes out, and the little LDL particle gets in there, pulls it into the cell, delivers the triglycerides, the phospholipids, whatever else is in this, in the particle, and then eventually the little particle hand, or the LDL receptor, goes back out and asks for more. Typically, that thing can stay out there off and on for 2 to 3 days before it kind of breaks down and your body has to build a new one. The more of those little particle receptors that sit out there, the faster you can kind of grab things that are floating in the bloodstream and pulling it into the liver. So there's a drug that will work on that, which we'll talk about a little bit later in the therapeutics. So you clear it into the liver then takes the cholesterol and again uses its own needs, or if it doesn't need any more, it puts it in the bile and puts it in the bile duct and sends it to your colon. The ileum actually will reabsorb a lot of it and kind of send it back through the system. And in about 15% of people, they will hyperabsorb. They'll pull more of their cholesterol back into the system than their body, needed. So, there's better treatment options for those people, so that once the body said get rid of this stuff, the body actually does eliminate it. The bile acids go into the gut. The bacteria that are in the gut basically digest it, turn it into something else. They stanol, and then the body can't reabsorb that, and then you basically eliminate it. So, you make the cholesterol. You got to then usually, with the liver, pull it into the liver. The liver then secretes it, gets it into the gut, and then it goes out the other side. So you can kind of attack the issue from any one of those sources. And, this will kind of go into, initially we'll talk about kind of, I'm not going to go too much into the lifestyle things. I mean, I'm not going to assume anything, everybody's their own N of one. But if you're eating, highly processed standard American diet and have abnormal lipids, well then start with eating real foods. And I'm not going to prescribe an exact diet for each person on here tonight. That's going to be more your individual context. But if you're eating a complete crap diet and you have abnormal lipids, start there. Exercise, of course, is going to have an effect on lowering lipids because your muscles, your metabolic currency, your metabolic engines. The more muscle mass you have, the more beta oxidation they can do. They can pull in those triglycerides, burn for energy, and you're going to lower your lipid levels, having more muscle mass. So exercise, of course, is going to help with this. But we're mostly going to talk about the pharmaceuticals and some of the nutraceuticals that can have an effect on lipid lowering. So first, figure out, should you even be considering lowering that? If you've already had a heart attack, stroke, stents, bypass, yes, the answer should be yes, unless there's a major reason you can't be on these medications. If you primary prevention, you're 35 years old and just have high cholesterol and a calcium score of 0, lifestyle, maybe nutraceuticals, rarely you're going to jump to the pharmaceuticals at that stage. Always risk first benefit, anything you put in your system. But the workhorse for lowering LDL particle number in ApoB, which I'll mostly be talking about tonight, is ApoB. The ApoB is that kind of apoprotein or lipoprotein. I should say it's an apoprotein on the outside of lipoprotein. Sometimes the terminology gets a little complicated, but the lipoprotein is the carrier, the apoprotein's on the outside, and just lets the body recognize what that thing is, so that then when it comes to the receptor can bind onto it and pull it in. But most of the LDL particles, I should say most of the ApoB particles, 90% of them or so are going to be the LDL particles. So, if I talk about LDL particle number or ApoB, they for the most part mean the same things. Yes, there are VLDL particles that have ApoBs on them, but let's leave that for another talk sometime. But the main goal is decrease production in the liver is usually the first goal for most of the pharmaceutical agents. That then will cause the LDL receptor to be upregulated. So statins, one of the major ways it works is it blocks an enzyme called HMG-CoA reductase, and that's about the third step down in a 37-step process of making cholesterol. And that's one of the reasons maybe some of the side effects of the statins is that it's blocking other pathways other than just the cholesterol synthesis. So the way you think about it is that the statin causes the liver to say, man, I don't have enough cholesterol for my own needs. It will upregulate that LDL receptor, put that LDL receptor back out, and be looking for it in the bloodstream. Maybe another cell said, I don't need this cholesterol, and put it back in the bloodstream, and the liver now pulls it into the system and uses it. It's never going to deplete your cholesterol levels to 0. So it just brings it down, pulls up the LDL receptor. That's the main way to think about how statins work. Side note on statins, I get this question frequently, some people think it should be in drinking water, some people think, it's not fit for human consumption. It's more nuanced than that on both sides. Use the right tool for the right job. But some of the people who tend to have issues with the statins, the things that I do probably a little bit differently is I will actually look for some root causes of why they have the issues. And the main one that most people have are the myalgias or the muscle pains or exercise intolerance when they're on them. And there's certain statins are more likely to do that. The hydrophilic ones, the atorvastatin, which used to be Lipitor, or simvastatin, used to be Zocor. Those ones tend to cause more of the muscle aches because they actually get into the muscles more. Rosuvastatin, which used to be Crestor, Pravastatin or Pravachol, and then there's the one, I think it's still traded at this point, pitavastatin, and those ones tend not to cause as much of the muscle ache, so pick the right statin if you're going to think the person is a good candidate for a statin. But then, yes, it's blocking cholesterol production, but also is going to deplete coenzyme Q10, which is a substance that your body is making, helps shuttle energy in the mitochondria, the organelles that make energy for you. So depleting CoQ10 in your muscles will likely cause them to cause pain, so you can supplement coenzyme Q10 to clear your levels back up if you're on a statin. If you're vitamin D deficient, you're much more likely to have myalgias, and I always recommend people use Mother Nature. The D-Minder app is free. It tells you what time of day to be outside to optimize your vitamin D status. If you're hypothyroid, underactive thyroid, you're more likely to get myalgias. If you have an ApoE4 gene, you're more likely to get myalgias and more likely to have side effects to any of the statins. And then there's a gene called SLC01B1. If you have 2 abnormal copies of that one, you may not tolerate any statins. If you have 1 abnormal copy, maybe you only tolerate low dose or intermittent dosing. So, you don't need to use high dose gorilla statins, every single day. For people who say I can't tolerate any statins, well, have you tried intermittent dosing? You can use rosuvastatin once or twice a week and still get a significant benefit. So work with your doctor and figure out, is there a reversible cause why you're getting myalgias on statins? The other thing that tends to help lower ApoB is a medication called ezetimibe, used to be known as Zetia. It blocks the cholesterol reabsorption at the gut level, so the body has said this cholesterol is time to go. There's basically a ticket taker in the gut. Niemann pick one type 1 receptor or something like that. I think that's very close to how you would say it. It just lets the cholesterol back in. So ezetimibe blocks that receptor, and so the body said it's time to go, it's time to go. But another place that the ezetimibe works is at the bile acid being reabsorbed into the liver. So if the liver has put the cholesterol into bile acids and said time to go to the gut, well, the bile can also get reabsorbed right back into the liver. So ezetimibe will block it at that spot as well. And so if you put it in the bile, it's going in the gut, and while you've blocked it there too, it's leaving the body. So you can help eliminate it from that standpoint. And there's a lab test that you can check to see if you're a hyperabsorber of different sterols. If you are, ezetimibe is probably one of the better medications for you to take then. The other newer medication that really lowers LDL particle number, or ApoB, are the PCSK9 inhibitors. Those are going to be Praluent and Repatha. Those are injectable medications. They can lower LDL particle and ApoB, I think somewhere up to 80% in some instances. Those are mostly used for people who have familial hyperlipidemia, so they have, total cholesterols. And again, I don't routinely look at total cholesterols as a metric of risk, but if your total cholesterol is 400 or 500 and you're not doing something, or I should say it's really high from a young age, maybe you've had something different happen in your life and you had normal and it went up, okay, that's not going to be familiar. But if your levels have always been 400 or 500 on your total cholesterol, it's very likely to have a genetic abnormality. That's either you're overproducing or your just body doesn't clear it very well. And so some of these people, like I said, end up with vascular disease in their 20s and 30s. They can be on high-dose statins and not getting to goal and they're having recurrent events. Those are the best candidates for those type of medications. And of course, I have a couple patients on them, but not that many. But the way the PCSK9 inhibitors work is that little receptor that clears the particles, I said after 2 or 3 days, it kind of degrades. So the enzyme that degrades it is PCSK9. So if you give a medication or a nutraceutical that blocks that enzyme, the little catcher's mitt stays out longer, clears more stuff from the bloodstream. So that's the main way that the PCSK9 inhibitors like Praluent and Repatha work. There's a fourth agent that really is brand new to the market, bempedoic acid. I don't even honestly know what the trade name for it is yet, and it's one of those things that I'm probably not going to use it anytime in the near future. I had a very wise professor in medical school teach me that don't be the first doctor to try a pharmaceutical, but also don't be the last. Yes, they might have proved that it was safe in certain clinical trials, but wait till it hits the general population and tens of thousands of people take it, and then kind of see where things lay. So if it was a world beater and absolutely prevented every heart attack, cool, I'm going to jump on board. But if it's just one other tool to lower LDL particle number ApoB, I got other tools in my tricks, so I'm not going to jump on this one right away. But essentially the way it works is it works upstream from where the statins work in the cholesterol synthesis part of the pathways, and lowers the LDL particle number. I think somewhere around 15 to 20%, very similar to ezetimibe as monotherapy. But the main benefit of this medication is likely to be that for the people who are, quote, statin intolerant, this medication is liver specific. It can't get into the muscle cells, so it's not going to affect the mitochondria in the muscle cells, so they're not going to get the muscle pains. So it would be very good for those individuals. Excuse me. So those are the kind of traditional workhorses for that. The other kind of prescription medications, there are the fibrates. Fenofibrate is probably the most safe one. There's gemfibrozil as well, but it has a lot more drug-drug interactions, so it isn't used as much. But the fibrates are very good for diabetics. Helps reduce microvascular complications, so retinopathies, neuropathies, the nephropathies, damage to the kidneys, the very small blood vessels. So it gives, for the most part, the same benefit as being on a statin, They kind of fell out of favor, but in my practice I still use them. People have high triglycerides. I don't necessarily use them to raise HDL. That's not really a useful metric anymore. But for people who can't tolerate statins, fenofibrate is an option. Then there's the omega-3s. There are prescription grade versions of omega-3s. The data is very interesting. Honestly, I just don't use a lot of them, just because of the cost. Honestly, I might check blood levels of your omega-6 omega-3 ratio, and I want you to get through your diet if at all possible. But if your levels are low, typically I'm going to use a nutraceutical grade omega-3 if I really think that's going to be the most optimal thing for you. I rarely would use just omega-3s just to be lowering lipids. I'm using them for more anti-inflammatory purposes or plaque stabilization issues. So, but omega-3s have some benefit as well, and there's data that's very interesting on using just EPA. But for anybody who's following me for any length of time, it's the DHA that's extremely important for getting energy from your environment to transmit it to your mitochondria. So those are the kind of big actors from pharmaceuticals. And the nutraceuticals, I would call them kind of green statins or statin alternatives. That's going to be the red yeast rice, which honestly is a statin in Asia. It's just a more, I should say, less potent statin, has less side effects. And some people tolerate red yeast rice, they don't tolerate statins. Challenge is you got to have a very high quality brand, because there are sometimes contaminants in red yeast rice that have caused kidney issues. So if people are on them, come to see me and their numbers are fine, the kidney function is fine, I'll tend to leave them on it. But honestly, I don't usually start people on them hardly anymore. Another kind of statin alternative works in the same pathways of blocking HMG-CoA reductase is going to be a supplement called bergamot. It's the rind of a citrus fruit in Italy, and it's not going to block the CoQ10 pathway, so not nearly as potent as statins, but sometimes it's a good starting point if people can't tolerate statins or just actually decline to start them. It's something that might help with lowering ApoB. Another one that typically we'll use is berberine. Berberine is a very weak PCSK9 inhibitor, so it's not going to be nearly as strong as Praluent or Repatha. But one of the things that happens sometimes over time with statins is that the LDL receptor, is being told to go out there, but then you also upregulate PCSK9 that starts eating up those receptors. So potentially if you get bergamot with it, you kind of knock down that PCSK9, the receptor stays out a little bit longer, so you kind of get a better synergistic effect using statins or anything with berberine. The other benefit of berberine is that it helps with glucose metabolism. It's somewhat analogous to using something like metformin or glucophage. Niacin, I still use it on occasion. Mainly people have excessively high triglycerides, but I don't use it this time to quote raise HDL. There's really no data that raising your HDL through nutraceuticals or pharmaceuticals gives any type of long-term benefit. You're potentially doing harm with it. In a couple of weeks, well, I don't know if I'll do it next week. Likely I will, but we will do a talk about lipoprotein a or LP(a). There are certain patients I'll still use niacin for that because that has a slight benefit. But we're still waiting on the antisense oligonucleotide trials that we're going to come out probably in 2023 to really know that if lowering LP(a) through a nutraceutical or pharmaceutical is giving benefits in MACE, major adverse cardiac events. So, if I can make your numbers prettier, great. But if it doesn't reduce your risk of dying or heart attacks or strokes or other type of things that are actually important to you, it's not that useful. And niacin sometimes is very challenging to use because you got to get the right formulation. You usually got to get to a higher dose. And there's a lot of flushing sensations, and sometimes it can cause insulin resistance or increasing your glucose. So niacin is sometimes a little bit trickier to use. So that's kind of the main things I would use. Personally, I've never got into LDL apheresis. That is a very specialized type of treatment. There's only a few centers in the country that do that. It's basically like low-level dialysis where they pull your blood out, they spin it out, take out the particles, and put your blood back in. It's a treatment that was used mainly for people with familial hyperlipidemia who are homozygous, had 2 abnormal copies, and had excessively high LDL particle numbers, tens of thousands probably. There may be benefit for those type of people, but now that the high-potency statins and the high-potency PCSK9 inhibitors out, those are probably going going to be relegated to very few cases. It's much more common in Europe than it is in the US. So that's all I have for tonight about going over lipid treatment. I know it was kind of a whirlwind of ideas, but this is being recorded and you can always watch the replay. I do thank you guys for your attention, and I'll open it up to questions now. And thank you everybody on Instagram, Facebook for joining tonight. Thank you everybody for the feedback. So guys, if you need anything, I'm always available in my office in St. Louis at Apollo Cardiology. I do telemedicine visits for those that don't live in the area. And if you have a quick question, best way to usually reach me is on Instagram. My handle's at Dr. Twyman. So I do have a question here. Can you ever stop taking lipid lowering prescriptions? The context of the patient is always the key. So, if somebody's already had a heart attack, stent, bypass, surgery, strokes, likely they're not coming off lipid-lowering therapies. There are targets that you need to hit. If somebody's had an event, I would like to see your ApoB probably in the 50s to 60s, and your LDL particle number in the 700s. But, if you can get down with lifestyle and nutraceuticals, then yes, you can potentially come off some of the pharmaceuticals then. And then question ranges, I think I just said it, ApoB 50s to 60s or LDL particle number, well below 1,000. I do not monitor total cholesterol. I do not necessarily monitor HDL cholesterol. I will kind of look at the triglyceride HDL ratio. Is a very, very rough estimate of insulin resistance, but it's not even that sensitive, especially in different populations of races, where it doesn't mean anything, but I do look at the triglycerides. In your traditional panel, ideally I like to see triglycerides well under 80. And most labs are going to say it's normal under 150, but that may be a marker that you're starting to lose control of the way you dispose of glucose if your triglycerides are starting to build up in your bloodstream. This is a good question. I did skip over this part. There's a question: how does cholestyramine work for cholesterol lowering? That is a more old school medication. It's a bile acid sequestrant. So your liver is putting the cholesterol into bile salts. The gallbladder then pumps out that bile into the gut, but the ileum was reabsorbing it. Well, if you bind it up with cholestyramine, the stuff doesn't get reabsorbed, and you eliminate it out the gut then. There are some benefits of it used for certain detoxification protocols, mold, especially, and then some of the bariatric surgery patients end up on it because they don't tend to absorb those things very well, bile acids very well. So it's an older school medication. It's a little bit challenging to use. You got to take it multiple times a day. It's been many, many years since I've prescribed it. Question, somebody saying, I've been taking niacin, sounds like you don't think it's necessary anymore. Again, I can't prescribe or de-prescribe medications or supplements over the internet. It sort of depends on why somebody's taking niacin in the first place. If it's just to lower lipoprotein A, it's a possible benefit over time. We're not going to know to 2023 if that's truly beneficial, but if it's to try to raise HDL, there's not really great benefit at continuing niacin. question, would you say that fasting almost 24 hours prior to a test would alter your numbers by liberating fats and ketosis? I don't know for sure if 24 hours would be enough fasting for that. It may take up to 72 hours before you truly reach homeostasis with that. So, again, checking a traditional lipid panel or an advanced lipid profile, you want to do it at your kind of normal baseline. If you're doing some type of biohacking or self-experimentation, yeah, maybe you want to see what your numbers are when you do those things, but you don't want to make big decisions, if you're doing something outside your ordinary. This is why, patients come into the ICU and they're, extremely sick. Their lipids are going to be very abnormal. Their body is in fight or flight response, and their body is going to be making a ton of cholesterol because you're trying to pump up your white blood cells to fight the infection or whatever else is going on. So your lipids are going to be extremely abnormal. That's not your normal homeostasis. I've not personally done a 24-hour fast and then check lipids. I know there are some people that really get into the kind of water-only fast to see what their metrics are. It's one of those things that, for the traditional test, for the most part, fasting lipids, it does affect your triglycerides. So I will check that in certain instances, but it's actually becoming more interesting what your non-fasting triglycerides are. So I don't always now request people fast for their lipid checks. Question about homocysteine. Very complicated topic. The best way to think about it is, if your levels are excessively high, it can cause the arteries to calcify, and one of the side effects of high homocysteine is it affects nitric oxide production. So if you have low nitric oxide, you're going to end up with endothelial dysfunction. There's numerous reasons you can have high homocysteine. So I don't want to get into a too awful sidetrack on homocysteine tonight, but that is a very good test to look at, in addition to a traditional lipid panel inflammatory markers, homocysteine and uric acid. Question about what is the test for nitric oxide. There's numerous ones. There are, so I have it in my drawer here. So there are different test strips you can get. There's a couple different companies that make them, kind of litmus paper. You put saliva on it, look at the color, gives you an idea of how much nitric oxide is being made from your saliva. You take dietary nitrates, turn it into nitrites, eventually gets converted into nitric oxide. So test strips you can do. Blood work, it's mainly looking at ADMA, SDMA, asymmetric dimethylarginine, symmetric dimethylarginine. There's also a test that I perform in my office in St. Louis called the EndoPat. It measures the endothelial function directly. Essentially looks like somewhat like a pulse oximeter. 2 of them on your fingers, measuring the flow in the fingertips. And you put a blood pressure cuff on one arm, pull up the blood pressure cuff over the systolic blood pressure, temporarily cut out the blood flow to that hand, and then you open up the blood pressure cuff and you get something known as reactive hyperemia as the blood rushes back down into the hand. The small blood vessels see this big slug of blood coming back, and if they're healthy, they release nitric oxide to accept that big slug of blood. And you can measure the degree of dilation. So your arteries should dilate by 68%. The test is called the reactive hyperemia index. So 1.67 or below is abnormal, 1.68 and above is normal, but optimal is greater than 2. So you want your arteries to at least double in size on an EndoPat type test. And patients come in my office and they've never had an event, primary prevention. That's one of the tests I'm going to recommend, because endothelial dysfunction happens 6-7 years before you're going to actually start putting plaque in your arteries. If you already have plaque in your arteries, the goal is don't have an event, don't have a heart attack or stroke. Let's try to freeze the plaque in place and ideally try to get it to progress a little bit. Rarely does it go all the way back to 0, but can stabilize and don't cause an event. That's the key. And if you have healthy endothelial function, you're less likely to keep putting plaque down in your artery. A great question. I usually try to keep these about 30 minutes. If there's any last burning questions, just shoot them below. But otherwise, I do thank you guys for your attention. As always, I do appreciate it. And I'll be back here next Monday, 6 o'clock Central Time. And I'm pretty sure the topic's going to be lipoprotein a. Week after that, actually, I think when I feed on the beach at that point, I'm going to be down in Cancun doing what I tell people to do: get some light water magnetism, recharge the cellular batteries. I'll probably do like a Ask Me Anything. So if you think about whatever topics you guys might be interested in, and I'll do a Ask Me Anything from the beach. So thank you for joining, and we'll see you guys again next week.